of our patients. And if it truly is cost savings, then I'd like to be able to prove that. So I'd just like to request that information. Thank you.
Okay, Representative Murdoch.
Thank you. In your recoupment breakdown, if you can go back to that slide, are you going to provide, you may have said it, I missed it, you're going to provide a breakdown more of what those numbers, where that recoupment came from? And did you collaborate with OIG on that? So
I collaborated with DHS. We worked to get these numbers. We put in an information request, and we worked with Mark Story, and the vast majority of those are deceased recoupments.
that's the math for the 17.
The 23 million here on the right.
Right, it's 23, it's deceased.
And I will go back because Mark wasn't there. He's on vacation this week, but we did confirm that with him. But I'll go back and see if there's any other amounts in there. Could be some that are over 65 Medicare, but probably very low. But I'll get that for you, Representative.
Thank you.
Any others?
Yeah.
Okay, Senator Sanders.
John, real quick, when you look at the claims data that you've received from the private option, I would like for you to do an analysis of those high-cost cases, particularly in those conditions that were clearly in place prior to coverage. So let's just say person signed up for the private option, and then like 2 months later, we're looking at them like end-stage renal disease. We've got a transplantation or something that was high cost that they should have been picked up by the medically frail screener, maybe, because the carriers have a mechanism by which they're able to, if we miss somebody on the medically frail, they have the ability to move them back over. And we had sort of in the early phases we dealt with pregnancy like this. If you were pregnant before you signed up for coverage, that pregnancy would be handled by Medicaid. But and the reason is this, because the idea of medically frail is to get them out so that they can be targeted, so that the department could explore options, be it through the PCMH or through case management, have the privilege of focusing on those high-cost cases. And what we want to know is if the carriers are needlessly hanging on to individuals to balance out their medical loss ratio. So I think that's, and so I'll tell you, when we look at, I know when the CSR reconciliation and ML reconciliation take place for 14, we think we're going to get in the neighborhood of anywhere from 15 to $20 million back from carriers. So that hasn't been factored in any of the PMPM costs. But I think what's important is looking forward. So how do their high-cost cases square? What does the MLR, CSR look like? And are they retaining individuals who should be on medically frail status and who should be in some level of case management?
Okay. Senator Chesterfield, you're recognized.
Thank you, Mr. Chair. I have a simple question. Is the Inspector General, and is that person here?
It's
Elizabeth Smith.
Smith, and she will be here tomorrow.
He will be here tomorrow. How many Inspector Generals have we had over the last 2 years?
I believe she's our second. This office was just created, I believe, in 13.
In 13, we had 2 Inspector Generals in 2 years. What is the status of the staff there? Is it fully staffed?
I think that's a question we can go over with her tomorrow. I don't know.
I'm asking because I'm not going to be able to ask that tomorrow. I would appreciate if you could find that information for me.
Absolutely.
Because we have a certain amount of allocations for staff, and I'd like to see what is going on and hope that it is not what I have been told. Mr. Stephen, when you look at the healthcare independence accounts, you had 4,000 cards returned since the beginning of this year due to bad addresses. Other than that, what have we done that is positive as far as these independence accounts are concerned? Are they bearing great fruit, or is the sole purpose to find out who did not bring back or whose cards were returned?
Stephen really analyzed this area, but from my standpoint, I don't think that you could say that one way or other what impact it's been having, but other
Is it
than,
reducing cost?
I can't answer that right now, but it's certainly not, it's not
Is it not
clear.
increasing efficiency?
I could check into that in the future, but we haven't looked at that, so I want to be careful not to say something that is not accurate, because that's an important question. I think that the problem is the way the account is structured, Senator. It's not really, and when we talk to the CEO and his team, it's not really proactive and personal, it's not real personal responsibility driven. So there really isn't a lot that I think you're going to see out of those accounts as far as a personal responsibility, taking action, really making changes in behavior. But I want to be careful because we really haven't analyzed that.
That would be helpful to me.
Okay.
Because if we're going to have programs in place, then there needs to be some mechanism by which we can judge, rather than just having programs in place. The other thing that's concerning me, Mr. Chair, is not just Stephen Root, but to you and our co-chairs, is the number of committees that we have working on this issue. There are a plethora of committees that are dealing with the same thing, and I'm saying Stephen at Stephen Root at Peter and Mr. Sears at Peter, I'm seeing them at JPR, I'm seeing them at Health, I'm seeing them at the Marketplace, I'm seeing them here. And you begin to wonder when do they get a chance to do the job that we have put them in place to do. So is there some plan then to coordinate among this large, oh, shut up. I just like to see us all meet together, because we cannot continue to push staff nor Stephen to 15 different committees and hope that we are going to have efficiency. So that's my concern.
It's a valid concern, and I had a conversation with Richard and with John since our last meeting about multiple requests that have come to them to go to different venues, to come to different meetings. And after discussion with DLR staff, it needs to be clear to the task force, I know it's clear to John, that they are engaged by this task force and DLR, and anything that distracts them from accomplishing the task and the scope of work that they've agreed to, they're not going to do.
Thank you so much.
And again, I think we've now again, there are going to be some things when it does produce value, and then we'll go to other committees if there's contracts that they have questions about that are inside the scope of work. But as far as they have gotten very clear direction that their function is to work for the task force and not to be dragged off on other errands.
Well, I appreciate that, and I do hope that sometime perhaps health, public health, and this committee can pass.
Well, and I think we'll talk about that. There may be a desire in August. The governor's going to come and want to address the task force, and there may be a joint meeting with the governor's steering council, and there may be an opportunity for the health. As I said, there's going to be a lot of interest in some of the meetings that we have, and we want to make those joint meetings, so long as we coordinate what's going on. I think that might certainly be appropriate, because we don't need to say everything, make them say everything 3 times.
And so, and finally, the one element that I'm finding missing is the disparity impact of healthcare on minorities. And I would hope that at some point in time, I could visit with you and Representative Collins about bringing in some individuals to deal specifically with minority health. And I would like to get with you to discuss that, because I think that has been a part of the conversation that is missing. And it is a relevant part of it.
And it was displayed quite clearly when we looked at the geospatial data that we got and how there was such a disparity on different parts of the city and different parts of our state. So it certainly is relevant, and we will have a hearing on it. You bet. Dr. Bledsoe.
John, you didn't specifically get to this part of your presentation, but on page 35 on the pharmacy, one of the questions I had, you were talking about, it looks like opiates and the overuse of opiates. That's something that, as an emergency physician, I've been really concerned about over the last few years. We've seen a surge of people dying of overdoses, people being diagnosed with addictions to these opiates, mostly prescription drugs. And I was wondering if you could just touch on that for the task force, because this is a growing epidemic. It's often seen in the South, and I think it's a big problem for our state as well as across the country.
And Dr. Bledsoe, we've had a request, I think it's a good one. Clarify for us, competition, what you mean by opiates.
All right. Yeah, so opiates are narcotic painkillers. It encompasses other things. The street drugs would include heroin, but prescription drugs are things like Norco, Lortab, Percocet, OxyContin, oxycodone. Morphine and Dilaudid and Demerol are usually IV drugs that are used in the hospitals, but all of those things are good painkillers, but they can lead to, at a high rate, obviously, according to the statistics that we're seeing now, of addiction problems and dependence issues. So that's why it's such an important thing for the state, because I think if you look at the data nationally, about 10 years ago, we started to see a surge of complications with opiate addictions and overuse. And I think it has a lot to do with some of the misguided policies on the federal level that had unintended repercussions. But
Yeah, Mr. Chairman, Rory Rickard from my team is going to be giving this presentation. I can have him come up here and answer that direct question, Ms. Bledsoe, or you can wait till he's going to be coming in after the individuals speak on behalf of their companies.
this afternoon?
Right after the presentations that follow us.
Okay, great. That's perfect. That'll be fine.
Okay, Floyd, you want to ask a question? We got, members, here's what I'd ask you to do is, this report, you should all have a hard copy with it. Take it home and make some notes of some questions you'd like to ask. And also, if you haven't done the same thing, do it to your first report that we got in the June meeting, because I have some that I want to ask, and we'll have an opportunity again, either late today or late tomorrow, to go through those things, because there is a tremendous amount of data here. So, here's the plan right now, is as soon as Senator King has a couple questions he wants clarification on, they're going to be brief, because we're going to try to get pharmacy started so that we can see how far we get to that before we take a lunch break, and we've got a lot to cover. So, Senator King, you had a couple questions on the report. Where are you at?
Gotcha, great one. Thank you, Mr. Chairman. I just have a couple of questions. On page 18, we looked at the average annual growth in Medicaid spending 2010. How hard would it be, and it's not a big deal, I mean, we can find it, where you go back and look the last 8 years, since 2007? Would that be too hard? Okay.
No, we can get that for you.
Then the second question on page 25 on the use of Form 703, what you're talking about the nursing homes, and they determine the eligibility of this, and don't mention home health care. How many states follow Arkansas's model?
I mean, a lot of states do follow the model, but it's the way it's used in practice. The ADL, one ADL with substantial need for help, assistance for daily living activities, assistance with activities of daily living, substantial assistance, life-threatening. The broad category is more here in the dementia category, and that's from your Department of Health nurses, and I think that's a little different the way that's written compared to other states. But those are CMS-approved levels of care. They're very strict on certain levels of care. So there's a standard area, Senator, in many of the states. What the problem is how it's interpreted, and what is the primary focus. And if you deem someone nursing facility eligible based on those levels of care, that does not mean they need to go to a nursing home. The waivers, that's what a waiver is, allows you, when you have one, to be able to provide community-based care services even when, and someone has to be determined nursing home level. Interestingly, in your state, when you're determined nursing home level and you're provided community-based waiver services, those assessments are done by your state nurses.
Okay, and just to remind folks, August meeting is going to have one day devoted to long-term care
Yes.
nursing homes. So.
Okay.
All right, that's all we have right now for the report. We're going to go ahead and move to the next item on the agenda. So if we could Assistant Mayor Mr. Palmer are excused for right now. And if you have things you'd like to add to this discussion, please let the staff know. We'll get you recognized to comment on it.
And Rory
But-
Martinez, Mr. Chairman, Rory is going to come up, I guess, at the end, so he'll.
Yeah, I mean, we've got 3 or 4 chairs up there. We've got 4 people to testify. Brent Breeding is first, then Mark Riley, then Dwight Davis, and Roy Rickard. So if the 4 of you want to come up, it might make it go faster because there might be some areas that y'all want to comment on each other's testimony. So we can get one more chair pulled around there. And while they're coming up, members, if you have your Stephen Report appendix, I ask you to turn to page 33. And you'll notice the prescription drug cost for the Medicaid program for the last quarter was $106 million. You'll notice that the previous quarter was $95 million, an increase of $11.4 million, the highest dollar increase of any of our items, 12.01%. If you look down at the private option, you see $11 million was spent in the previous quarter. For this quarter, 3.6 in the previous quarter. Now that's a growing population, but still, you can see these are both, and that's a 3-month total. So we're talking about a $400 or $500 million program at least. And I'll also say that this is the program that we found the quickest savings for when we began to reform teachers' insurance and state employees' insurance. Thanks a lot to Mr. Davis and some of the work they did over at the AMS. So this is a real opportunity for us to look at how we can do things smarter and better. So we're going to start with Mr. Breeding. If you're just state your name and tell us what you do, and you're recognized.
Good morning. I'm Brent Breeding. I'm the Arkansas County Manager for Magellan Health Services. We are the pharmacy vendor for the Medicaid program. We brought in as such, and we process the pharmacy claims. We have a point-of-sale adjudication system. We have a full-service call center that helps providers when they have issues with getting claims to pay or they have authorization requests. We do a segment of those as well.
Would you just briefly, and I saw in the report where it talks about you all as the, and I think there's an oversight or somebody that's over that's assisting you all, or how's that relationship work?
Can you clarify the question?
Tell me how the program is administered right now. If a Medicaid patient needs a prescription, how does that process work, start to finish, in layman's terms?
Okay, well, the overall program, which is administered by Dr. Burton's staff, the state unit, and there's Kyle Santi, which is the project manager office that oversees the entire organization. We're the pharmacy vendor, so the recipient goes to the doctor with the prescription at the pharmacy. Pharmacy processes that claim and comes through our point-of-sale system, and it tells them if it meets criteria or not, and how much they'll get reimbursed for that claim. That answer your question?
Yeah, I think so. Well, do you have anything to testify or to give about improvements that could be made or cost savings that could be brought to pharmacy administration of our Medicaid program?
No, to be honest, I wouldn't give much guidance on what would be asked here, so I think, kind of off the cuff, but I will say Dr. Durden and his staff have always done a extremely good job of having most of your criteria such as ensure that patients get medications that it's medications that are approved.
And what is the guidance now regarding whether it's a generic prescription or a main name brand?
Typically what happens is if a lot is based on rebate and how they did it as far as the rebate process will have to pay, but when there's only 1 or 2 generics, there's really not much savings, so then there's no requirement for the pharmacy to dispense the generics. However, there is a $2 preferential fee that they get on top of the regular dispensing fee that they do dispense the generic in exchange for the brand name. But then when there's multiple generics out there, and then when you see the big cost savings from a brand to a generic, then one of our staff members is a MAC allowable cost analyst, and he works with the state in establishing the MAC prices. Then they're required to they dispense brands they want to, then we get paid at the maximum allowable cost rate. So what they'll do is they'll use the generic. To get brand name at that time, a physician would have to get a authorization request that the brand may be necessary for authorization
to Mr. Riley. Dr. Riley, you're recognized to tell us your thoughts on the pharmacy administration program, and I know you and Dwight were very involved in our reform of the other programs, but tell us what your experiences are.
Thank you, Mr. Chairman. I want to thank you and Chairman Collins and members of the committee for allowing me to speak today. I want to give you just a little bit of quick background. The first slide, does everybody have a copy of this? No.
I think you've got to run the computer there and start the presentation.
I'm not sure it's on. I think we have hard copies that we had here passed out. Everybody's got it? Okay. Just want to make sure everybody has it. Okay. The first slide there is just the things we're interested in. I'm going to read those very quickly and then come back to them later. We want to take care of patients. We look for stability and predictability in programs because we think we do better in those situations. I'll talk about one later. Be able to practice at the top of our license, to use those, be able to do those things we're trained to do. Having incentives to use the most effective and lowest cost medications. We think basically the evidence-based approach is really important in pharmacy programs. Having local control and the benefit administration that I'll go back to later, and creating a win-win-win for patients so that the intent of the physicians in treating their patients and achieving the best outcomes can occur. Pharmacists are medication experts. They have about 15 times more pharmacology than anybody else in healthcare. So what we do is drugs and understanding how they work and why they work and how they affect patients. And the community pharmacy system right now, I think one of the things that's really important to this discussion is that pharmacists are really the only healthcare professional in the equation that knows both the therapeutics of medication and the economics. And that's really important right now. We know what drugs are used for in the same classes that can be used for the same issues, and we know what the relative cost of those medications are. And so I think that our expertise is important as we look forward to treating patients, getting good outcomes, and controlling costs at the same time. Pharmacists, we believe, are the most accessible healthcare providers in Arkansas. You walk into a pharmacy at any time to have a conversation with a pharmacy. There's at least one pharmacy in every county in Arkansas. In smaller communities, many times pharmacy is the only healthcare provider, and we hope that we can continue to have a viable industry so that those stores and those centers and those communities can continue to exist. Economic impact, we thought it was important just to talk just a second about the economic impact of pharmacy. There's 791 retail pharmacies in Arkansas, according to our State Board of Pharmacy. 415 of those are independents, 376 are chains. You can read those statistics, $2.4 billion in revenue, and the average employee salary is about nearly $46,000 in pharmacies in Arkansas, not including benefits. Our survey that we've made we've made our extrapolation very conservatively. The numbers may even be stronger than that, but we made sure that they were conservative. The Arkansas pharmacy marketplace, I think, is maybe what you may be interested in. The next slide. 90% of all prescriptions are paid for by third-party payers, such as a PBM or Magellan or somebody that processes the claims. 14% of all prescriptions in Arkansas are Medicaid. This is based on a survey of our members who said that on average about 14% of their prescriptions are Medicaid. Generic medicines are responsible for 85% of all prescriptions filled in Arkansas. That might indicate to you why we had some legislation this past time addressing generic reimbursement. It's very important when almost 9 out of 10 of every prescriptions you fill are generic. It's important what you get paid on those drugs.
Is that 85% of number of prescriptions for dollars?
Of all, no, just numbers of prescriptions. 85% of the prescriptions. The numbers are very different in terms of money. I don't know what the latest Medicaid numbers are. Last time I looked, I think there was like 75% of the prescriptions in Medicaid, this has been a few years ago, at that time, was 75% for generic, 25% brand, but 72% of the calls for brand and 28% generic. So it's almost a reversal.
So the 15% that are not generic are
brand name drugs that cost 3 times or more than 3 times. Medicaid have to give you those numbers. I don't have the current ones.
Saying the dollars are somewhere around 75-25 for the non-generic drugs.
Very close. Very close. I just haven't seen the latest ones. Sorry.
I guess that kind of speaks to the difference in price.
Sure.
That's what you recommend.
Absolutely.
Thank you, sir, and good morning. One of the things that, as we pursue the conversation around healthcare reform, and it's good to see you here, is the difference in pharmacological impact among ethnic groups. And one of the things that always troubled me was the Tagamet example. When I was asked to take Tagamet and found out that it had a disparate impact on African Americans. What is the pharmacy association doing to help provide information that would allow doctors to make more informed decisions when we start talking about medicines, be they generic or non-generic, that may have a disparate impact on particular groups?
It's the reason we support the evidence-based medicine approach, is because the evidence-based medicine takes all that into consideration when decisions are made, whether drugs are preferred in the network or whether they're allowed, as opposed to just, okay, who gives me the biggest rebate? You know, because if you do it that way in therapeutic classes, then you don't take into account all of those idiosyncrasies that deal with patients. But if you do it on an evidence base, based on the literature, what it says about the drug, and what the effectiveness is in various populations, then you can make those decisions correctly through an evidence-based approach. So that's why we support that particular.
Thank you, Mr. Chief.
Okay, go ahead, I'm sorry.
No problem. Reductions in generic reimbursement have caused over 90% of the pharmacies to make changes in their operations. Again, we've done a pretty extensive survey. These pharmacies have said that they're delaying hiring, they're laying off people, they're cutting salaries, they're cutting hours, and so the generic reimbursement issue has been really big for us. Aligning payments so that patients, pharmacists, and payers win by using the most effective, least expensive drugs. And again, I'm describing evidence-based medicine. I think that's the vote. The other thing about low payment on generics, and the reason I keep going back to this, is it creates misaligned incentives toward using more expensive brands. Right now, one of the things we need to look at in the Medicaid program, and we're trying to open our chest here a little bit too, is that we're paying about $3 less gross in our studies looking at various states around us in Arkansas. We are paying about $3 less on generics than we are brands. We think that's a misaligned incentive. We think that we should be encouraging generic drugs while we seem to be moving toward just continually cutting those low-cost drugs even lower and lower where they're unprofitable to dispense.
So who determines the reimbursement that you're paid?
In Medicaid, they do it, and they do a pretty fair job.
Who's they?
Excuse me, Medicaid does makes their decision.
Our local DHS or?
Well, they have federal upper limits. They have FULs they have to work within. In other words, they can't go above those. But then they have some discretion within the state to make differences when drugs change prices and all, to adjust those.
So the other state, you said the other states are paying more than we are?
It varies by state. Some pay more, some pay less. It's all over the board. We have some statistics we'll be glad at some point if you want to bring to us there. I don't have them with me today.
Do most states pay more for generics than for name brand?
It varies. Some do, some don't.
Why would you pay more? Why would a state pay more for a name brand?
Just because of the way the formulas work out, sometimes it establish that. And I just want to bring that to your attention, that our formulas, we pay about $3 gross more brand than we do generics. They're quite more expensive, and so it just works out that way.
Well, can I just ask Mr. Breeding what your thoughts are on that? Why are we charging more for generics? I mean, paying less for generics than we are for name brand, with a perverse incentive to use more expensive drugs?
I don't really think, in Mark speak up, I don't really think that in Medicaid we are. To answer your question, Dr. Durbin says we have a set pricing structure, unless a federal limit applies. But I don't think that from a percentage standpoint, we are paying more for brand than we are for generic.
So you don't think we are, but you think we are?
Well, what I'm saying is the gross margin at the end of the day is a function of discount off the drug plus a fee. And when you take the brand name drugs and figure that, and you take the generic and figure that, we're paying about $3 more on brand. Now,
Are you saying you make more?
About $3 more.
So you're talking about what your profit is?
What our
not
gross
what your
profit is. Our gross profit, our margin above cost, works out to about $3 more on brands and generics. I just wanted to make that point because the alignment, the incentives are important.
Mr. Roy, would you like to comment on this? I saw you shaking your head there, because again, I'm still having issues understanding how we're getting different stories.
I think you clarified it for yourself, Mr. Chairman, when you said it's what the profit is after the equation is done, not what they're paid for the process of dispensing the prescription and the cost of the ingredient. So Mark's comment was about profit in the cigar box after he does the brand transaction versus the generic transaction.
Is that driven by rebates or by what the drug manufacturers are charging, or why is there such a higher margin on name brands? Just because it's at a higher dollar and the same percent applies?
Same percent doesn't apply, but it has a lot to do with the difference in the gross difference in the ingredient cost. A brand drug for 30 days cost could be $300. For a generic drug, it could be $50 or $60. So if you are working in percentage formulas, percentage off larger numbers could drive, could be larger dollars left over at the end of the equation.
Yeah, I'd rather make 2% on a 100,000 gross than 20% on a $5,000 gross.
Yeah,
So I guess what I want to know is, and I guess this is, either one of y'all may want to answer this, or how do we fix that? Because the taxpayers are the one who's getting burned on this. If the drugs have the same effect, we're not helping the patient. All we're doing is, paying more for a drug that does the same thing because of this difference in pricing. Has any state solved that problem?
I don't have the data from each state in front of me, so but our point is the generics need to be incentivized. Medicaid doesn't do a bad job of doing that. Even though they try to be very fair on it, it still winds up about $3 difference just because the brand names are so expensive. And so when you figure the percentages, we just noticed in our data that there was about a $3 differential. And we thought, well, there might need to be a discussion about should generics be incentivized more. I don't believe our pharmacies are using that incentive in that direction because we've encouraged them to use the generics and they're going on the formularies that are set up, the evidence-based formularies, and I think they're dispensing what needs to be done in the statistics showing over 85% generic use says that the generics are being used.
Okay,
I just wanted to mention that in passing.
We'll come back to the dollars though. 15% is 75% of the cost if those first numbers were right. Senator Irvin, you got a question on it?
Yeah, quick question. Is there a baseline Medicaid dispensing fee, and what is that for every Medicaid patient pharmacist gets paid?
The maximum fee is $551. If pharmacists can bill up to $551. Then there is a
fee on top of what you're talking about. Is that correct? A dispensing fee on top of what you're talking about.
No, the dispensing fee is part of that whole equation. That $3 difference includes the dispensing fee. It's total reimbursement.
Total is $551.
No. The total of the $3 difference is on numbers that include the dispensing fee and the drug cost margins.
Okay, so total, how much would that be?
Well, I think the number is about 14 on brands and about 11 something on generics. I think is what it worked out. I don't have it in front of me. The point I wanted to make is that even though Medicaid tries to be very fair and do it very well, it still winds up slight disparity because the brands are so high, which is what Mr. Rickert was explaining. But in the private market, the disparities are just getting really crazy in terms of get paid nothing for generics, which doesn't make any sense from an incentive standpoint. So I didn't know.
All right.
I wasn't real finished.
Oh, I'm sorry.
No, is there a reason why is that into incentivize pharmacists to treat Medicaid patients or to accept them as clients, or is there a reason beyond? Is there a reason for the dispensing fee other than just a dispensing fee as part of the formula? Is there any reason behind it? Like you were talking about incentives and changing. Is there an incentive behind? And you're shaking your head, so you might be able to answer this one.
Well, I understand your question. The math that Mark was explaining is pharmacy goes and buys drugs. So we've got an ingredient cost, the cost of goods sold invested in the prescription. They have professional services and rent, administrative services to run the store. And they get paid a reimbursement for the ingredient cost they bought, and a professional service fee, the dispensing fee. And Mark is saying that when you sum those up for brands versus generics, there's $14 in gross profit for a brand and only $11 in gross profit for a generic. I said, well, a lot of that can be driven just by the gross cost of the product.
Right. And how does that compare to like private insurance
In the
or Medicare?
In the commercial world, you've seen dispensing fees much lower than the Medicaid dispensing fees here in Arkansas.
What about across other states?
In terms of Medicaid,
Yes.
in Medicaid, you're probably in the middle of the path for dispensing fee nationwide. We plan to bring you information, detailed information on that in the report. We don't have that today, but quick look is in the middle of that path.
Okay, Director Seeley, do we have a pharmacy guy here from DHS?
We do. Dr. Jason Draper, too.
If you wouldn't mind coming down, we need a bigger take on it. What would you like to add? And the question I have for you and for anyone else down there that wants to take a stab at it is, can states just say, we're only going to authorize generic drugs in cases?
You can actually, well, this is a very complicated situation, and we're talking, I think, apples and oranges on some of this. If we look at our generic utilization in the state of Arkansas, our last numbers are 85%. So 85% of all drugs that are being filled in the community are generic drugs. Generic drugs are typically less expensive than the brand names. In addition to that, we can do what we call a maximum allowable cost. We can put that on that group of generics. This is the maximum amount that we'll pay for any of those generics, and it also applies to the brand. So it pushes utilization to use of the generic products. We do have where we have branding that is necessary, but I think Brent was explaining that, where physicians can, if the brand is truly necessary, if there's some kind of adverse reaction with generics, if they're not getting therapeutic response they're wanting with generics, then they can request that. But if you look at what we do with our brand, and I don't want to complicate this too much, is that you look at the top 25 brands by claim in the Medicaid program. Those are the ones that we actually want them to use because we actually get a federal rebate and we get a state supplemental rebate with contracting directly with manufacturers. So the top 25, all but 2 are what we push over to our drug list, and we collect another rebate on top of that, and that rebate actually brings those brands down below the generic cost. So generic utilization is great, and we maintain it very well through our generic deliver or maximum level cost program. But if we're talking about methodology on payment, that's a whole different situation. When we look at how we do our methodology, we have what we call an average wholesale price. The average wholesale price is kind of like when you go to a car lot and you look at the particular price on the window. We know that you can probably negotiate that down. So what we have with that is we have the average wholesale price for a generic is AWP, average wholesale price, minus 20%. We'll give you what we pay for the ingredient cost of that generic. For a brand, we do AWP minus 14%, and that's what the ingredient cost we pay the pharmacy for that brand. In addition to that, we pay for professional services of the dispensing fee, which is $5.51. The brands, for the brands that we have brand company out there, and we have one generic company. So there's access problems. We cannot put a maximum allowable cost on that. We like to make sure that we have access to medications. We do an incentive fee of $2. So if we have a brand out there and very limited use of a generic or limited access to a generic, we do an incentive fee so that we can put $2 on that to push the use of that generic over the brand.
Do you know how I see we've got a question for Representative Gray. Representative Gray, you recognize.
Thank you, Mr. Chair. I wasn't expecting to be recognized at that moment, but I guess when I kind of asked for some of you guys to come today, and kind of what I wanted to see was the difference in processing between how we do it in Medicaid and how we do it in the private option. And Mr. Stephen, at one point in one of our last meetings, had mentioned that possibly not using a PBM could be a cost-saving measure for us. And so I just want to make sure that we go through the process of how Medicaid works versus how like Caremark, US Scripts, Catamaran work for our private option population. And I'd like to be able to see what the cost difference is, maybe even per enrollee, if that makes sense. And I've talked to a lot of pharmacists throughout, the last few weeks about how Medicaid works versus the other PBMs with the private option. And for the most part, the pharmacists have been very, they've all said the process with the Medicaid is very fair. They have no problems with appeals, and the dispensing fee, and the way that you guys use your MAC pricing list is very fair. And so I just want to make sure that we're able to compare the private option PBM versus the Medicaid PBM to see the difference.
Can I clarify one thing?
Yes.
The Medicaid program does not have a PBM.
Well, and I'm sorry, that's what they ended up coming back and telling me is that did you guys have like a fiscal agent?
We have a physical agent, which is our claim adjudication. We have that a system where all the scripts that come through can actually get paid. So that's what Magellan does for us. They have a call center and make sure the funds go through. So the state actually takes care of the programs, and they oversee the Magellan contract for claim adjudication. We have what's Dwight over there now? We have Dwight and the ABRX, our preferred drug list, and then we have our state unit that actually does the recommendations for our drug utilization review board, which is going on today, and they look at claim criteria on the medications that would come out, and then we have our in-house maximum allowable cost. We have two people, one at the state office and one at the Magellan office that does the maximum allowable cost, which all feed back to us for approval, or actually to the pharmacy program and Medicaid.
Okay.
So everything's handled internally with Medicaid.
Okay, would there be a way that we could get total administration costs for the Medicaid population versus the private option population? Like if you guys, I know that since you have the fiscal agent and you guys do some things internally, what's your total administration cost versus the private option cost?
I can get the cost for our program as far as if you're looking at staffing and things
Yes.
like that and contract pricing. And to clarify a little bit more, CMS does require certain things that have to happen for you within the Medicaid program. There's no choice about it. We have to have a retrospective representation review program out there that we have to contract out. We have to have a DUR board that reviews criteria for drugs. So a lot of this that we put out there is required by CMS. But if you look at what the Medicaid population and Medicaid program does, we are different than an insurance company, private option, totally, because we do collect federal funds and we have state funds. But you look at what we were able to do when you take into account the federal rebate program that manufacturers are required to do to get a drug covered by Medicaid. And you see where we spent, I think, for fiscal year 14, we spent $326 million. That's a lot for prescription drugs. But on that, we recouped back, or I don't want to say recouped back, our rebate invoicing brought back about $160 million back to the program. Now again, we don't get to keep all that, unfortunately, because we are federally funded, so that most of that goes back to the feds. But when you look at net year to year, 2013 fiscal year, we spent I think right around $302 million, and then we had an increase up to 26 to 14. We collected more rebate in 14, so when you look at the overall spend, we had less than 1% spend for those 2 years because of the increase in rebate that we were able to collect. And then with our program that we have with the EBRX, and we're able to collect, in addition to the federal rebate, that state supplemental rebate, which is about 10 to 15 million in addition, or on top of what that 160 million was for 14. That's how we're a little bit different. And one of the biggest differences in the Medicaid program versus an insurance company is we don't have formulary. If a drug manufacturer comes out and they sign a rebate agreement with the feds and it's FDA approved, we have to make available for coverage in the Medicaid program. We can't exclude drugs that meet that criteria of a covered outpatient drug, and that's in federal law on that. So, but the feds give us certain other tools that we use to build control costs as a framework of this Medicaid program.
Okay.
Okay.
I'm just gonna tell you in general, having dealt with this for 2 years, the rebate program drives me crazy because it is impossible to understand what's going on. It distorts the financial picture when you try to make policy decisions because of that. And like you said, 70% of it probably goes up back to Washington. It is so hard to understand what the net cost of things are when they're playing these games with the rebates. And for what it's worth, it makes it very difficult to really assess what the facts are. And I guess what I would, and I think what Representative Gray is exactly right, is what we're trying to figure out in this discussion today is what is the most efficient way to deliver effective prescriptions to the people who need it. I guess we can get good data on the Medicaid program because we administer that through contracted PBMs or whatever we call them. The private option is going to be more difficult because we pay insurance premiums and we have to get all the the data from the carriers, which we're striving to get now. But I think the point she makes is exactly right, is we do have an opportunity to compare which of those delivery mechanisms is most effective. But we have to know, without rebates and with all that stuff included, what's the net comparison between those two delivery models. And I guess I'd ask Roy, is that something that you guys are going to be able to provide to this task force?
It will depend on our ability to get accurate rebate data. I know that's the thing you don't like, but that's the wild card in the commercial PBM servicing the 3 private option carriers. So as a task force and as a Stephen Group, we're a couple arms length away from those rebate payments on a per claim basis or gross basis. So it's going to be hard to see what the net comparison. Your original question is a great question, but coming back to you with a really accurate answer on that is going to be, it will be difficult.
Who gets the rebates and the insurance carriers get the rebates for that program?
They collect rebates, manufacture rebates for programs that they administer.
And do they, when they report the claims data and the cost data, are they going to give us that information as well as part of that?
Well, it's a difficult, that's a simple question. Here's a difficult answer. The rebates trail behind some 210 days. So we're getting claims data from last quarter and the quarter before. The rebates may not even be collected for those yet. So it's an awesome question with a really hard answer. But we're going to endeavor to try to guide you through that.
Okay. Senator, any other questions?
Yeah, one thing I want to let Jason talk about is response time, and because we've been on the phone about this, and I appreciate the work, and if you don't mind, I have a follow-up question, but I want him to share with this group of folks what they've been working on in the response time, because they have really managed that response time for pharmacists and physicians, because physicians now, because we're not able to get a lot of the information we need in our clinic, call the pharmacist in town, and they run the Medicaid eligibility card, because they can find out quickly if they're eligible or not, whereas we're sitting on the phone for 30 minutes. And so if you can share that, I would appreciate it, and then I have a follow-up question for it.
You're talking about our call center. We have our EBRX, our preferred drug list, that has a call center. We call it pharmacy, Working John's, another call center. We do get reporting that on that. And this is something that Dwight and I have had conversations on in the past. And he's got the same philosophy of us, is if there's a way to do better, we want to do better. And we were noticing that there was a trend in the call center at our drug list that the whole time was increasing more than what we would want it to be, more than what Dwight wanted it to be. So during that discussions, he was able to get that restructured, and over the whole time that it was, an average whole time over a minute. This last June report came back down to around 21 seconds. And that really is beneficial to the providers that are calling, that they're not sitting on hold. They don't really have the time in the office. Pharmacists don't have the time in pharmacies to sit on hold. And the same thing for what we have with Magellan for the physical agent. Their average hold time, I think, time to answer a question, I've got that number here, is about 22 seconds. We have performance indicators for both groups, and depending on how the contract's set up, we want to make sure they stay within those key performance indicators. And that's just one part of it. The number of calls answered, the number of calls come through, the time it takes to actually resolve a situation, all that's monitored through our program, and make sure that we do best for our providers, but more importantly, best for the recipients of the state.
I just want to follow up, if you don't mind, Mr. Chairman, saying that's so critical and important, particularly personally on prior authorizations, when you're trying to treat your patient, and you're trying to figure out what's paid for and what's not paid for, and what you can because if that patient leaves and without their meds, good likely chance they're not gonna get their meds for the next month or 2 months. I mean, it's just so critical that we need to have that same structure in place for your healthcare providers that are providing the service, not just their pharmacy. So and then follow-up I wanted to ask too is, and this is information just on, I'm concerned, I just want to see our structures, to different providers across the board. So average wholesale pricing on generics versus brands, what that is, what actually is being paid to, so we can get a clear financial point of view on this for pharmacy, because I think that's important to see. Is there a need to incentivize generics? If they're getting more money, I don't want to see that. I want to see that we're balanced. I think there's got to be a big rebalancing, I think, across the board sometimes for Medicaid, but I want to be able to see that, if you can add that information on wholesale pricing, and then the need for incentivizing or not incentivizing. And then the rebate, just to follow up on the rebate too, how often we change those rebates and how often does that happen? Because I know sometimes in the Medicaid program, my frustration is this was approved and then all of a sudden it's not approved. And then we're changing these meds for patients back and forth, and that causes a lot of health complications.
Yeah, I can speak a little bit about how our preferred drug list does and preferred medications. It does sometimes seem like they get changed a lot, but we require certain reports to be provided. So we have our initial report that comes through our drug effectiveness review program, and then that goes through a whole process, and it determines which drugs are preferred and non-preferred. Those aren't changed until there's a new report or it's re-reviewed. So that could be 5 years down the line, it could be 2 years down the line. So there is some changing of that drug list, but it has to do with when new reports are available and when the re-reviews are done. So let's say for drugs that we have a big, 10 different drugs, brand drugs come on the market in one class, that's our PDL. That's usually an indication that they get reviewed quicker to get those back where we may be able to get a better rebate for the state, and those will be reviewed a little bit quicker, so we make changes. And then a lot has to do with manufacturers. We have manufacturers that agree with us for 3 years. Manufacturer at any point in time can drop out with notice. And so that could occur too.
Yeah. Okay, thank you.
Okay, Mark, Spicer, just 1 minute. I finally found the question that I had for Mr. Breeding, and it was actually the first report. It says that you guys are overseen by Cognostate.
Dr. Santi is a project management officer. In the new RFP, new MMS system, there are 4 contract service. The core vendor, which HP is, the pharmacy vendor, which is us, and then the data warehouse vendor, which is Optimus. And the 4th contract was for a project management officer to oversee the operations of all of those, kind of go between the state and the respective vendors. And it's a company called Cognizant.
Are they still doing it?
Yes.
What do they do?
Just to make it federal, define that, and I can't, but they, make sure we do what we're supposed to do.
I mean, because obviously one of the statements in here is the question, basically the question, the need to have, don't you all do this in lots of other states? Gentlemen?
Yes, we do.
And you have project office management people over you in all the other states?
To my knowledge, the other states that we are the pharmacy vendor, no, there is not a project management office that oversees us.
So how much are we spending on that project management office?
Question I can answer. I can get that back to the group and let you know. We have a team in the state that will go into that question. What Cognizant does is we have 3 people on this contract that work with Brent and work with the state. They provide specific expert background on certain issues, like one of them has really big background in interfacing and understands the systems and system issues, technical issues that as a pharmacist above my head, I cannot tell you how computers need to hook up and how to get rid of firewall UMS and stuff like that. But so that's what their expertise is to make sure projects are completed in a timely manner, but they do the testing and also provide insight on how the project can be performed.
Okay. All right, Mark, we'll try not to interrupt you. What we want to do, folks, is let's let you finish your presentation, then we're going to take a break for lunch. Dwight, you're going to be right up after lunch, if that's okay. We'll finish up the pharmacy section of this thing. I do want to talk about, the elephant in the room is what's the impact of the legislation we passed in the last session, and what's that going to do to Medicaid costs, and the private option costs, and the private industry costs. So we'll have a couple questions about that, and then we'll roll over to the next section. But Mark, why don't you go ahead and finish up what you got?
Just a comment, that was just a passing comment. I didn't mean to get us off, that we just noticed that existed, and we were doing all of our analysis. I will say this, that in the Medicaid program, we're confident that 100% of the money that comes from pharma because of the uses of the drug gets to the program's bottom line. That is simply not true in the private sector. That money's carved up among several people. So just thought I'd make that mention. We think Medicaid does a really good job of making sure the money goes to the bottom line. My next slide is additional pharmacy services that we think we can do to help in long-term in healthcare and getting positive outcomes and getting the intent of what our prescribers and our primary care physicians and others want to accomplish in Arkansas. Appointment-based adherence model, and what that is it's keeping people on the medicines. We hear, I've talked to you, Senator Bledsoe, several times about physicians bring a patient in, they try to give them, what they're supposed to take, and then it's a nightmare to whether they take the medicine or not. One of the things we think pharmacy is perfectly outfitted for is to be able to monitor that adherence, make sure people stay on the medicine that they're supposed to. We've had a study that we just finished this past spring in Arkansas. The results will be out this fall, and it was funded by Pfizer through the National Community Pharmacy Association, and I'm proud of the fact they picked Arkansas to do the study. And we had about 70 stores that had software systems where they could identify patients that were likely to be advantaged by adherence, people that had multiple disease states that were on several maintenance medications, they just, had those kinds of problems that they need medicines they really needed to stay on. And so the way this has worked is through a synchronization, MedSync we call it, where a patient will get one day a month, maybe their day's the 14th of the month, or the second Thursday of the month, and they come in and all of the meds are filled at one time, so there can be a discussion so that it can be reviewed, everything that's been changed. They'll get called before they come in to say, has anything changed? Has your doctor changed anything? Do I need to talk to your doctor about anything? Are you having any problems with any medication? It's just a general overview to make sure that people haven't stopped their medication for some reason that nobody knows about, and that they're doing what they're supposed to do based on their physician's instructions. So that we're waiting for the results on that program. What we know is that was based on a platform called Simplify My Meds, that its data over the last 2 or 3 years has shown that it has increased adherence or taking their medicine by 3.3 fills a year, which was greater than a 50% increase in what the numbers were, but people who weren't seen, if you took the average. So they were taking about 5 or 6 prescriptions a month, and with that it took it up to almost 9 prescriptions a month. And it's face-to-face verification that they're taking the medicine, not just saying they got it, but that they literally took it. So we're looking forward to those results. Next slide, the second thing on that slide is medication therapy management, which is a deeper dive into a counseling situation where patients with multiple disease states are getting prescribed from several physicians, specialists, and others, where that somebody is taking a look at how all those medicines work together, not just that they're taking them, but what are the problems that arise. Quick story, if I might. John Vinson, who is our current president, was the pharmacist at the AHEC in Fort Smith for a long time. He's working statewide now over some of those programs. But he said they had a model where the pharmacists, the physicians, the nurses, everybody met regularly and worked together and tried to really have the team approach that we talk about. And he said one of his jobs was that at the end, before every patient was discharged, that he did a final review on everything that happened while they were there on their medication and looked at where they were. And I'll use his words. He said, Mark, not 90% of the time, not 95% of the time, not 98% of the time. He said 100% of the time, there are significant issues with drug interactions and things I have to go back and with physicians and I sit down and talk through because one physician has prescribed something that creates a problem with what another physician has prescribed within the AHEC. So he said, you know, it's just something that has to be looked at if we're going to take care of patients taking their medicine right. And my comment back to him was, you're working in a system where you're doing everything you can to avoid that, and yet it's happening, what's happening out here in the real world where communication is very limited. So medication therapy management has been used now for about 8 or 9 years in Medicare Part D plans. Most of the plans are paying for that, for pharmacists to do that, so we have some experience with it. And the last thing on additional services is in the area of immunizations. About 70% of pharmacists immunize now. One of the problems we've really focused on lately is that we're really low in infant, pediatric, and adolescent vaccines, immunizations. And the health department's talked to us about helping with that, but I've had discussions with several of you about that, and the pharmacists can't be paid. They're working on that now, and I think they're figuring out a way maybe to be able to do that. Now, understand, we cannot do immunizations under 7 years old. Pediatricians handle all that, and that's appropriate. And from ages 7 to 17, any immunizations that a pharmacist does has to be done on order of a prescription. And then above and then in adults, we can do all those immunizations. Flu can be done down to 7 under a general protocol. It does not require prescription. Any other immunizations we do would be working with physicians as they would prescribe that to be done. So there's collaborations going on that now. The other thing, y'all asked us to come what we thought and tell you what we think to do. And one of the things we think it's time to take a serious look at a single administration of several of the state programs. And we say up front, Medicaid's a different animal. And if it was brought into the group, it would take significant waivers and time and looking at it before you could do that, simply because there's so much federal intervention. Dr. Durden said a while ago, mentioned that, you know, if a drug pays a rebate to the federal government, then you have to put it on the formulary. You don't have a choice. So those kinds of restrictions, if they're rolled in, there's going to have to be waivers so that you can make the hard decisions like we think evidence-based medicine does and saves money in the state employees and those other and the industries they deal with. Medicaid's different, and so if we're going to be able to roll those together, there's going to have to be some concessions from the federal government to allow that flexibility.
Rory, do you know, would those provisions be waiverable under the 1332 or some of the waivers that people talk about, the provisions he's talking about having to have these drugs on the list?
Some of those things could be waiverable, yes. I don't know that we get a clear line where the program for, say, state employees, public school teachers, and people who service Medicaid could operate exactly alike, but you could get waivers to some of the differences.
So you could ask for a waiver to say, we want to have the ability to use evidence-based medicine decision-making versus mandates about specific drugs.
Yes.
You could leave the question.
So I just want to bring that up because it is different. And what you don't want to do until you get that worked out is you don't want to hold the other programs back from making quick decisions and as market changes and all. But we believe that using the evidence-based medicine program, it has a track record now. It's been amazing in what it's been able to do to control costs. We like the idea of using a pure fiscal intermediary like Magellan is, some company that processes claims. What we found in the state employees, and I'm not here to pick fights, but what we found in the state employees in 2003 when I got here, I began to talk to Sharon Dickerson about their program. They were running about 20% increases and had for about 5 years. And one of the things we were able to do was get their consultants changed to get their program to a very transparent pharmacy benefit contract where it's basically processing and a couple other services they asked for. And that program overnight went from 20% increases to 2% increases. I think you and I have had those discussions, Senator Henry, a few times. And managed that program at that level for about 5 years. It began to creep up recently, and you did great work on the task force to get that back in place. But part of that reason is that they had left the principles of taking advice from Dwight. I'll just say what it was. And when we did that, I think we got that program back going where it needs to be again. So we think it's important that there's local control, that when when providers, physicians, pharmacists, whoever, need to talk to somebody when a patient has a problem, back to your point, that you can get it done. You know, and sometimes when we deal with out-of-state entities, there's huge hold times, and trying to find somebody to fix the problem is really, really difficult. So we want to, we think the EBXR formulary program that they run has indisputable success, and we think it could be spread across several state programs to take care of a cost in this state. We think we could save a lot of money. Back to my original.
Can you say, like, percentage-wise, what you've seen as far as reduction in cost because of the TBRA?
Well, in that program in state employees, it went from 20 to 22% increases a year to less than 2 for the next 5. I mean, it completely flattened out. And most of the moves since then has been, a lot of it's been specialty drugs. And Dwight's got some ideas for how we can start controlling the specialty drug market. But the typical, and I don't want to take any of his thunder because he has some things probably to talk about that I don't know about the program specifically. But what we know is in that program that those costs flattened overnight when the recommendations came from the pharmacy community. Pharmacists know how to save money in drugs better than anybody. We understand. We look at things that get adjudicated on our computer and shake our heads. Why is that being done? Well, it's being done many times because somebody's making money off of it that nobody knows about. And so the incentives get aligned to do things the wrong way many times with the number of hands that are in the cookie jar. So I want to wrap up here. I know we're forced on time. Go back to my original slide, what pharmacists are interested in, taking care of patients. We want to be able to work with local providers to improve health outcomes. We want to have stability and predictability because, quite frankly, pharmacists get blamed and get cost cuts many times when there are increases when it doesn't have anything to do with us as a provider. You know, generic drugs go up or brand generics go up, and we wind up getting a fee cut over it, which has nothing to do with it. I kind of amusingly always say it's like gasoline goes up $2 a gallon, and you try to solve the problem by cutting the attendant's salary by 50 cents an hour. It has nothing to do with the problem. And so more importantly that it's not fair, the most important thing, and this is what was happening with state employees at that time, is it keeps you from focusing on what is the problem. If you're making decisions and making changes that don't fix your problem, then it keeps you from focusing on what is the problem. And if we did anything, we were able to help them understand what were the problems to focus on. We want pharmacists to be able to practice at the top of their license, which means doing what we're educated and trained to do within our scope of practice. And then having local control, I think we talked enough about it. We just think that we see things run smoother when we've got people like the Evidence-Based Medicine Center and Medicaid running these things locally as opposed to outside companies. And then we want to create a win-win-win for the patients and the pharmacists and payers, and I'd add physicians to that. And we believe it can occur. We think we've had the evidence on the programs that we've been able to get involved in. We've seen those changes happen, and we've seen those savings. It's not a pipe dream. We've seen it happen. And so I just end with the last slide that we've left here our phone numbers and email addresses, and call us anytime.
One of the things I would ask that you and Dwight work with Roy on is what specific provisions would need to be changed from the federal perspective if we were going to try to implement the type of cost-saving measures that we were able to do on the other programs. All right, we've got one question, and we're going to break for lunch. So Senator Ervin, just realized everybody's hungry. You're right.
I will keep this short. I do think there's some value a lot to what you said. I just wanted to make one point though on the immunization thing. One of the reasons why physicians aren't performing immunizations in their clinics is because they are not paid to do it. They are not reimbursed enough to cover the cost of the medication, the cost of the appointment, and the cost of the time. So there was a point in cutting that reimbursement from Medicaid to push all of that to the Department of Health. So I just want to make sure that that point is very clear. I appreciate that you would say that would be an additional service that you could provide. However, there were reasons, I think, to push it to the health department, but it's not because the physicians can't do it or won't do it or don't want to do it, they can't afford to do it. So that just needs to be information out there. But I do appreciate, I think the organization and combining the state programs, I think that's a very valid point, and I appreciate that very much.
Okay, gentlemen, thank you for your patience. You got the hardest spot of the day right before lunch, but that's why I want to break, because Dwight, I'm looking forward to hearing what you have to say, and I'm sure we'll have some more questions. So we'll come back at 1:45 for after lunch break, and then we will pick up where we left off here. And folks, probably will be in committee room B, just so everybody knows. We'll have to reset over there because children and youth is meeting here unless there's